Hello and welcome. This is TDT Live. I'm Stacey Ann Providence. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago, and we're bringing you live coverage on TDT, Talk City 91.1 FM, Suite 100.1 FM, Next 99.1 FM, and on Facebook at TDT Live Online. We go now to the Manager of Corporate Communications at the Ministry of Health, Candice Alcantara.
Good morning and welcome to another edition of the Ministry of Health's virtual media conference, where we provide you with current and accurate information on the Ministry's COVID-19 response. As you will see, we're all wearing a touch of pink today in recognition of the end of Breast Cancer Awareness Month. It ends today, and this month seems to support the awareness, early detection and treatment of this disease. But please remember that health and wellness continues beyond this month. Today we welcome back the Honorable Terence Dael, Singh, Minister of Health. Additionally, we have our subject matter experts with us, Dr. Naresh Nandram, Principal Medical Officer, Epidemiology, and Dr. Avery Hines, Director of the Epidemiology Division of the Ministry of Health. I'm Candice Alcantara, Manager of Corporate Communication at the Ministry of Health, and I will moderate this morning. And we go straight into the opening statement from the Honorable Terence Dael Singh.
Thank you very much, Candice. Good morning to Dr. Nandram, Dr. Hines. Good morning to ladies and gentlemen of the media and the listening and viewing public, wherever you are on this good Saturday morning, Saturday the 31st of October. There are now 8 countries in the world, unfortunately, that are in the group of countries with over 1 million COVID cases. 8 countries. It keeps going up all the time. I think last week in Tobago, I had indicated there were either 6 or 7, and that very soon others will be joining. And outside of those 8, which are 1 million plus, there are other 3 countries that are 0.9 of 1,900,000 plus. And with the rate of new infections being discovered every day, which is about 575,000 cases globally per day. So the pandemic again is showing no signs of slowing down. It is only a matter of time before we have 11 countries with 1 million cases and above. What are we doing at a policy level in Trinidad and Tobago? I would have alerted members of the media and the national community some time ago that we were expecting for the first time in Trinidad rapid antigen testing kits. I am here this morning with a policy position to tell you, yes, the kits have in fact arrived, luckily on time, on schedule. They came in on Wednesday gone. And we have received 2 types of test kits, 2 standards, standard Q and standard F. The one that uses a reader, which you will see, Dr. Nandram will give you a demonstration. We have received 150,000 of those to be distributed eventually amongst all our hospitals and some community settings. And another one called Standard Q, we have received 40,000 of those. Those have a lower degree of accuracy, but they do have a role in community testing, and Dr. Nandram will give you an idea of how we plan to roll out antigen testing. Where does this new antigen testing fit in to the policy part of testing? You would recall every country in the world started off with centralized testing. In the Caribbean, we started off with CARFA. Then eventually each country developed its own PCR testing regime, and then eventually we started to roll out PCR testing and other forms of testing at the hospital level. So in Trinidad and Tobago, we have CARFA, we have Trinidad Public Health Lab, we have UE in Mount Hope, that lab doing PCR testing. We have North Central Mount Hope doing PCR testing. We have San Fernando General Hospital doing PCR testing. So that was part of the rollout of the decentralization plan. Then we introduced something called the Gene Expert machines, another form of PCR testing, which were low volume, but they give you the results in about an hour or so. We had those basically at TPHL in Federation Park, the Sangre Grande Hospital, and Tobago. So today marks a very significant day where we complete the decentralization of testing using rapid antigen tests. Ladies and gentlemen, you may recall when antigen tests first came on the scene, maybe around June, July, we were asked why we weren't using them in Trinidad and Tobago at that time. And the reason being, at that time, the tests, which were new at that time with new technology, were not accurate enough. As a matter of fact, they were giving you false negatives in the region of 25 to 50%, which is not a good thing to unleash on a population. The technology has improved, and not only improved, has become relatively cheap. The demonstration that Dr. Nandram is going to be doing this morning on a rapid antigen test actually cost us about $6 for one, as opposed to a PCR test in a laboratory setting, which costs about $100 for one. So you could see the great cost saving, but more importantly, this can be deployed around the country, Trinidad and Tobago, and will give the individual the results much quicker. So I will leave Dr. Nandram to go into details of that, how we plan to roll it out. In the rollout, it is not that we are going to roll it out immediately. Reason being, anytime you introduce a new testing regime, you have to validate it against PCR. You have to train personnel, which has already started. You have to choose your sites correctly. We have already chosen 5 sites, 1 in Tobago and 4 in Trinidad and Tobago. And that training and site selection has already begun to some extent. We started the sensitization last week, Friday, and during the course of this week, we had further sensitization and so on. So we are in a position within the next week or two to actually start the trial run of rapid antigen testing for the first time in Trinidad using kits which have a very high degree of accuracy. So that is where we are this morning, Candice. I want to thank you for the opportunity to alert the country to this major policy shift from centralization to decentralization, and thank you for the past few minutes.
Thank you very much, Minister. And Dr. Hines, you're now invited to deliver the clinical and epidemiological update for today.
Thank you, Ms. Alcantara. Good morning to the Minister, to my colleague, Dr. Nandram, to the members of the media and of the viewing and listening public. The clinical update for today is as follows. The update takes us to 4 p.m. yesterday, Friday, 30th of October, and as at that date and time, we have tested 33,014 unique individual patients, of which 5,668 tested positive. We currently have 32 new cases diagnosed or reported between yesterday and today. We have 1,106 active positive cases. Of those, 1,013 are in home isolation, 60 are in hospital, and 33 are in step-down facilities. We have 174 patients currently in state quarantine facilities, and we have 4,455 recovered patients, and 107 persons have passed on. And again, we extend our condolences to the members of those families. At this point, I will switch into the epidemiologic update, which is as follows. I'm going to do something slightly different this morning. Next slide. We're going to look first at the global update. And at the global level, next slide, we are looking at the spread of coronavirus across the regions of the WHO, colored as you see, the red being the Americas, the green being the African region, the teal being the Eastern Mediterranean region, the darker green being what they call the Western Pacific, and the yellow being the darker green being the Southeast Asian region, the yellow being the Western Pacific, and the blue being that European region, just to emphasize what the minister was pointing out with regard to global trends. Next slide. What we see is overall, if you look at the shape, not the color, the shape of the entire graph, this is globally, what we're seeing is that we are currently in a phase of global increase. The numbers that we're seeing at the right-hand end of the slide correspond to what the minister is saying, over 500,000 new cases daily on a global basis. And the colors then correspond to the regions that we just pointed out earlier and show the relative contributions of each of the areas. We see that the Americas, the region that we're in, is actually a very active region right now, driven largely by the numbers of cases and the increases in cases in North America in particular. Moving to the next slide, we recognize that although globally we are in a stage of increase, each region actually has a slightly different pattern. So while we see the American and the European regions going up, that's the red and the blue, some of the other regions, for example, that teal region, or the green region, which is Southeast Asia, and the blue and the slightly darker green, are all in a downward phase at this point in time, having had their peaks a little earlier. So although different regions are at different phases, overall globally, we are seeing that upward trend in the new cases. Against that background, next slide, locally, we have, as we described, 5,668 local positives, and we have 107 fatalities among our local population. Going to the next slide, our local epi curve, that epidemiologic curve showing us the number of cases by date at which they presented for sample collection, has been demonstrating that basic plateau pattern, that almost flat line over the month of October. We are currently seeing on average about 33 new cases per day. And while we are hoping that that continues to trend downwards, we do note that it's sort of hit a baseline level, which is what we're calling that plateau. Moving forward, the demographics remain fairly similar to previous reports. Next slide, with men slightly outnumbering women, being about a little over 52% of the cases being male. The vast majority of them, nearly 55%, being in that young working adult age group, 25 to 49, and the pediatric age group, that age group under 19, being constricted, smaller, because of the measures that have been in place to protect the school-aged population. Next slide. Among the fatalities, we have seen that 75% of those persons who have passed on have been men. The majority of them, over two-thirds of them, have been in the 60 and above age group. And we do note that while fatalities do occur mostly in the older age groups, we have had individuals under 50 and in some cases under 25 also passing on. And we do again emphasize that the existence of pre-existing conditions, what we call comorbidities, chronic diseases that they may have had before, hypertension, diabetes, chronic lung disease, chronic kidney disease, all of these things contribute to the higher risk of having a fatal outcome. So we want to again encourage all persons to be aware of their own status, to be aware of the steps that we need to take to protect not only ourselves, but our loved ones from having infection in the first place, by reducing risk, by keeping our masks on, by maintaining proper physical distance, by keeping our hands clean, by not crowding places, workplaces, etc., so that we have a lower risk of ill individuals coming into contact with well ones, and most importantly, by not going to work or going out into public if you are indeed ill and you have any sort of respiratory illness. Next slide. Geographically, we do see again that population distribution basically mirrors where we currently have cases. So where we have cases, it's where we have people. And this is really just to emphasize that there isn't any place at present that we can say is coronavirus free and we don't have to take these precautions. The precautions are necessary across the nation. Next slide. And this is more of a heat map. It gives us a slightly better idea of where cases may be concentrated. The darker red colors indicate higher concentrations of cases, and the lighter blue indicate lower concentrations. So you see where the population is densest around the Port of Spain and San Fernando areas, in the Sangre Grande and the Arima areas, in central Trinidad, Chaguanas, etc. Wherever we have lots of people, we have a higher concentration of cases per unit land area. So we just want to ensure that people are aware that at this point in the population, the virus is all around, and we do need to maintain that level of precaution even as we have begun to increase our movement, increase our mobility, increase our interactions with other people, as some of the restrictions have been lifted as at Monday of this week. So with that, I end the epidemiologic update, and I turn you over to Ms. Alcantara.
And we go now to Dr. Nandram, who will give us some more information on antigen testing, which Minister Dael Singh brought up and introduced this morning.
Honorable Minister, esteemed colleagues, members of the media, and of course, members of the viewing public, it is my pleasure to introduce rapid antigen testing to everyone here today. So I'd like to first just give a bit of background and compare and contrast the gold standard PCR testing that we have rolled out into Trinidad and Tobago with this new test that is currently being put into public health facilities. If I could have the first slide, please. So by way of accuracy and reliability, the gold standard test that we have been using as recommended by the WHO is polymerase chain reaction, or PCR. And it's noteworthy that, as Minister mentioned earlier, that very early in the pandemic, antigen testing was not terribly reliable. However, across the last few months, the reliability and accuracy of these tests has improved significantly, so much so that the WHO has now recommended 2 antigen rapid diagnostic tests for use. This test happens to be one of them. So by way of comparison, the technology PCR uses a molecular platform, and basically it looks for the nucleic material, the RNA of the virus, whereas an antigen rapid diagnostic test uses a very fancy sounding antigen-based immunodetection mechanism. Simply put, that just means that the test recognizes what the outside of the virus looks like and sticks to it. Now, in terms of the testing window, when someone can be tested, standard PCR can be used from the first day of testing, from the first day of symptoms, to about day 10. Antigen testing equates to roughly that same time period, but the documentation, says specifically in fancy language, the qualitative detection of antigens of SARS-CoV-2. So that means, quite simply, if the virus happens to be in your nose, when at the time of testing, it'll be picked up and you'll test positive. Now, the advantage of the antigen rapid diagnostic test really comes to play in the last 2 categories. Where can we perform a PCR test? PCR tests generally require a highly specialized laboratory manned by highly trained staff. Antigen testing does not require a laboratory at all. In fact, it's a point-of-care machine, meaning we can take this machine and put it as close to the patient as possible. So as you'll see in the slides coming forward, it is our intention to place these in the accident and emergency departments of all major hospitals in Trinidad and Tobago. So this is the standard biosensor F200. We have ordered 15 of these machines for deployment nationally and 150,000 test cartridges. This is the fruition of the overarching plan to move testing away from centralized labs and bring it closer to the patients. And this machine will give a printed result, and it can also be linked to lab information systems. The great advantage being that it can turn around a result in roughly 30 minutes of test time. In addition to the standard F200, we've also procured 40,000 of the standard Q cartridges. These tests are very similar to the pregnancy-style tests, and we plan to deploy these into smaller health facilities, rural areas. We can use them for outreach programs and such, and they afford a similar testing time of about 30 minutes. This slide shows the rollout plan for Phase 1 and Phase 2 deployment of these tests nationally. In Phase 1, we intend to deploy this test in every RHA in Trinidad and Tobago at all the major hospitals: Port of Spain, Eric Williams, San Fernando, Sandy Grande, and of course Scarborough General Hospital across in Tobago. In Phase 2, we intend to deploy these tests in the major health facilities, the district health facilities in each RHA, and we've also ordered an additional 4 machines that are in train. So I'd like to just show quickly the cartridges of these machines. So this is the test cartridge that's used with the standard Q machine. As you can see, the standard Q is a very small machine which will enable its placement into accident and emergency departments. It's a point of care machine, meaning that it can be used very, very close to the patient, and it can also be moved from point A to point B if so required. So 15 of these machines will be deployed during Phase 1 and Phase 2 nationally, and we've procured 150,000 of these tests. This is the standard F. By comparison, this is the standard Q pregnancy style test. This test does not come with a reader, but it does give a result with a line or 2 lines, very, very similar to pregnancy tests. So to utilize this machine, we would go to standard test, input the patient information, and then the cartridge would go in here, and the nasopharyngeal swab, which is the standard swab that we use for testing COVID-19, would be taken from the patient, immersed into a neutralizing buffer, which would neutralize any live virus at all within a minute or 2. So the risk to anyone using the test is minimal. Once the swab goes into the deneutralizing buffer, there's basically no risk of transmission, very, very little risk of transmission to anyone. So the buffer solution would go into this well, the entire cartridge into the machine, and the machine will give an automated readout. All right, that ends my little demo of the new antigen testing rapid diagnostic test. Ms. Alcantara, back to you.
Thank you very much, Dr. Nandram. And we enter the question and answer segment at this time. In the usual fashion, please, we invite our media representatives to begin by stating your name and the name of the media house that you represent before posing your questions. And of course, in order for us to get the most out of this segment, we recognize some time constraints. So please, no more than a maximum of 2 brief questions per media house. And we begin now with AZP News.
Hi, good morning. Private Harry, azpnews.com. The first question is to Minister Dael. Minister, there has been a call by people who use the gym. They wanted to know if it's possible for the hours to be extended from 4 a.m. to 10 p.m. because there's a lot of people now are going early to the gym, and they have to line up and wait, for the appointment at 6 a.m. And some of these people normally go from 4 a.m. In order to make work, etc. And my second question has to do with antigen testing. Would that eventually replace the PCR testing? Thank you.
Okay, thank you very much, Priya. So I'll take the first question. I have always resisted the temptation to make a policy on the fly. So you have asked me a question this morning. We could consider it, and when we are announcing further measures, it can be considered. But I will not commit at this point in time to making policy on the fly. Thank you very much.
Thank you. And Dr. Nandram, second question.
Sure. Does this rapid antigen test replace the standard PCR? No, it doesn't. This test is designed to work in conjunction with the PCR testing systems that we have in place. The rapid antigen test can be considered to be a screening test, the first line, because it's pretty good at identifying persons that are positive. Someone that tests positive on a rapid antigen testing can be treated as positive and just rapidly moved from where they are in under the screening tents or the accident and emergency departments into the parallel healthcare system.
Thank you very much. And we go next to CL Communications, please.
Good morning, Natalie Singh, CL Communications. I just wanted to find out one thing. This weekend is the first weekend since the Prime Minister announced that beaches will be open. Lifeguards are complaining they don't have enough PPE equipment. Is this cause for concern as it is a possible instance for the virus to spread? And then my second question is on the issue of the training for the antigen tests. What is the depth of training that has to happen and how long is it estimated to take?
Thank you. Thank you, Nadaline, for your question. So I'll take the first one. The issue of lifeguards falls under the Ministry of National Security, I believe. So I think you can direct your question to the Corpcom departments of the Ministry of National Security. Thank you very much. Dr. Nandra?
With regard to training, training for this machine will be fairly in-depth. Of course, it will involve the ability to actually utilize the machine, but beyond that, it will involve familiarity and running persons through the protocol for quality assurance and quality control, because we need to ensure that once a test result is produced from this machine, that we can of course trust that. So training on how to use the machine, on the appropriate quality assurance and quality control measures should be completed across the next few weeks.
Okay, thank you very much, Dr. Nandram. And we go to Newsday newspaper, please.
Good morning, Paula Lindo here from the Newsday.
Morning.
Good morning. My first two questions are to Dr. Mr. Dael Singh. Yesterday, the Scarborough General Hospital Medical Chief of Staff would have said there's a blood supply shortage in Tobago and also in Trinidad. Has this been affecting surgeries and other procedures here?
Okay,
so
sorry.
Second question, could you give us an update on the plans to reopen the borders? I know you're on the committee that's supposed to be reviewing that.
Sure.
Thank you.
So, in speaking with both the CMO and the Chief of Staff of the Scarborough General Hospital, I can tell you this, because we run it by the numbers. For the period January-July 2019, we utilized 11,228 pints of blood. For the same period, 2020, January-July 2020, we utilized 11,007. So statistically, similar types of numbers. In speaking to Dr. Victor Wheeler, who is the Scarborough General Hospital Chief of Staff, he did say they have a shortage of blood in Tobago, mainly because they did not go as they usually do on a voluntary blood drive. He indicated to me this morning, because I spoke with him this morning, that they actually went on a blood drive yesterday because we were concerned about it here in Trinidad. And he has assured me and told me that it is already bearing fruit, that that acute shortage should be eased up very, very soon. But Ms. Linda, you raised, I wanna give you a more complete answer. The issue of blood in Trinidad and Tobago and blood donation is one that has never really been fully tackled. There has always been reports, and good reports, validated reports, of patients not having access to all the blood they need at a particular time. This goes back decades. What we are doing at the Ministry of Health at a policy level, which I am responsible for now for Trinidad and Tobago, we have already set up something called a national altruistic, totally voluntary, non-remunerated blood donation program, which is in contrast to the current CHIT system, which could be considered you give blood and you get a reward. That goes against the grain of blood donation. In other words, you should not be given blood and expect something in return for it. So over the past 2 years, 2018, 2019 into 2020, we have developed that policy. We have calculated how many such donors we need. These are donors who are giving blood altruistically, expecting nothing in return. So they don't expect their blood to be assigned to their relative or their friend, which is the current CHIT system. We have worked out how many donors we need to have on that database, that if they give blood between 2 to 3 times a year, how many pints of blood we will collect in any 1 year. To move the process forward, we have already engaged, and UV does a lot of good work in this. I want to congratulate Dr. Kenneth Charles. He goes on blood donation drives very often, and we at the ministry, through Northwest RHA, have already started voluntary drives. So that's in its infancy stage. At the policy level now, we went out and advertised for a national director of the National Blood Transfusion Service. That person has been interviewed. An offer was made. I am hoping the person accepts the offer. And once that person is installed, his or her mandate under the new policy at the Ministry of Health is finally to convert this country from the current CHIT/remunerated system to a totally voluntary, altruistic, non-remunerated system of blood donation. That process we envisage is going to take a minimum of 2 years to a maximum of 3 to 5 years. Hopefully, once we start it and get the ball rolling, we can compress that 3 to 5 year horizon down to about 2 years. But it's a massive undertaking, not physically massive. It is going to involve a complete re-education of the public in what voluntary, non-remunerated, altruistic blood donation means. We are going to have to mount, and we have already started it in its infancy, a total public education campaign, knowing which sector of the population we are going to target, put them on a database, and now let them, and I used to be like that many years ago. I used to give blood altruistically 3 times a year, back in my younger days, with no reward. Use it however you want. But we need a group of people to do that. So just to wrap up the answer, Scarborough General Hospital went on a blood drive yesterday to relieve this acute shortage, but we are addressing the chronic part of it at the Ministry of Health with the policy measures I have just gone into some detail with. I hope that answers your question.
Thank you very much, Minister Dael Singh, who's always been passionate and a champion for true voluntary blood donation. I can attest to that. And we go now to TV6, please.
Hi, good morning. Alicia Boucher from TV6 News. I just want to follow up on that question about the blood. Has COVID-19 at all impacted that process for taking blood? Do persons have to be screened for COVID-19 before they give blood? That's my first question. You may have said it, but I may have missed it. Can you give me the accuracy for both the standard F200 as well as the standard Q tests that we ordered?
Thank you. Thank you, Alicia. So in terms of the figures, COVID-19 has not negatively impacted the period January to July. So let me just give you the figures again. January to July 2019 last year, we collected 11,228 pints. This year, in the midst of COVID, we collected 11,007. So statistically, that is an insignificant change, right? So we have collected roughly the same amount. What Tobago experiences is a short-term acute shortage, which they have corrected by going on a blood drive from yesterday. Okay? And I will let Dr. Nandram talk about the test.
So the accuracy of the test is in the region of the gold standard PCR. That's the rough range that it's at. Of course, how it performs in our local system is something that we will be validating, and it's really important to go through this validation process, not just with antigen testing, but with any new test being introduced into the public domain. Every manufacturer does the required studies and publishes specific figures with regard to, how the test performed when it was tested, during production. However, how the test performs in the real world is something that the Ministry of Health is keenly interested in particular in our setting. As you may imagine, the majority of tests are produced in first world countries, and the challenge with that is they tend to be tested in largely Caucasian populations. The population grouping in Trinidad and Tobago is far more diverse. We have members of the public coming from many ethnic groups, and that in and of itself, the genetic basis of our population can sometimes influence how a test performs in this setting. It is for that reason that the test is going to undergo a validation process by one of the most renowned agencies in the field, the Caribbean Medical Lab Foundation. CMLF has done work all throughout the Caribbean validating tests, and they're working closely with us along with the Pan American Health Organization, not just in validating this test, but also in the rollout nationally. So to circle back to your question, the test is similar in terms of reliability as per the manufacturer to the standard PCR, but the validation process in our setting is going to be performed for quality assurance and quality control purposes. Thank you so much.
Thank you much, Dr. Nandram. And I think we have a second question from Newsday that we in error omitted to respond to. It was directed to Minister Dael Singh, and the question focused around plans to reopen the borders based on Minister's membership in the high-level committee.
Thank you, Paula. I just completely forgot about it. I do apologize. So last week, Saturday in Tobago, I was there at that press conference. The Honorable Prime Minister appointed a three-man committee consisting of myself, the Minister of National Security, Honorable Stuart Young, the Attorney General, the Honorable Faris Al-Rawi, because the issue of opening the borders intersects with the three ministries, and we have to look at legislative framework, the national security issues, and the health implications. We had our first meeting on Tuesday under the chairmanship of the Honorable Stuart Young. We discussed various options. He gave each of us, including himself, some homework to go home and do. I have done my bit of the homework. I spoke to the Attorney General yesterday. He has done his homework. We will have another meeting over the course of this weekend under the chairmanship of Minister Stuart Young, and then Minister Young will present the findings of the committee to the Honorable Prime Minister, who will then make his decision based on what we are recommending. Thank you very much.
Thank you very much, Minister Dael Singh. And we go now to TTT Limited, please.
Yes, hi, good morning. Sonal Lala from TTT News. Minister, forgive me if this was mentioned before, but I had some connectivity issues. What determines whether someone is tested via the PCR as opposed to an antigen test? And secondly, if someone is tested via the antigen method, will they be retested via the PCR method to ensure accuracy? Because especially in the trial period, to ensure, because I know PCR is still the golden standard for that.
Thank you. So I think Dr. Nandram did go into some detail, and I will let him go into detail again. I will just give you the policy prescription being driven from the Ministry of Health. In the early rollout of any new novel testing system, you never unleash it without validation. So in the trial phase, which will start within the next week or two, we are going to be validating these new tests using CARPHA's validation system, which CARPHA used to validate the private labs and the Ministry of Health labs at UWI, San Fernando, and Mount Hope. So in the first phase, when we do our trial runs at 5 sites in each of the RHAs, most likely the accident and emergencies, there is going to be some parallel testing where you validate the results you are getting from the rapid antigen test against the gold standard PCR. And I will now let Dr. Nandram go into the more technical details.
Thank you, Minister. So to answer your question, Mr. Lala, absolutely. This is part of the quality assurance and quality control system. This validation of the test will ensure that the sample is run in parallel during this validation period. So basically, once a sample is taken and run on the antigen testing, that sample will also be run using the gold standard PCR, just to ensure that we can trust the test, that the rapid antigen testing in this setting, and that's part of the performance assessment of the validation that we'll be doing. So once we're outside of that study period, that trial period for validation, the reports coming out of there will inform us that hopefully we can trust once the machine says it's positive, it's positive. Once the machine says it's negative, and then we can trust it at that level. To address your initial the first bit of that question, what determines whether someone gets an antigen test or PCR test? The antigen test is a screening test. It's the first line test, and there are a few very solid reasons for that. The first is generally from the figures that we've seen from the manufacturer, is very, very good at picking out persons that are positive. And that's what we're really interested in, persons that are positive, that have COVID-19. So moving this point of care testing into the accident emergency departments will enable the doctors and the nurses and the healthcare staff there to determine very quickly if that person sitting in front of them happens to have COVID-19, and then action, based on that result. Beyond that, the PCR testing can still follow if the person, for some reason, did not get a positive test. To be 100% certain, the PCR test can also still follow. Right. So I trust that answers your question. Thank you so much.
And Sonal, just to let you know, patient 1 for this antigen testing was myself yesterday. We used me as a guinea pig yesterday, so I am guinea pig number 1, and my test came back as expected, negative. So that was the first trial run of it yesterday.
Thank you, Minister. And we go now into follow-up questions. We welcome a question now, brief and to the point, from AZP News, please.
Hi, good morning again. Minister, I want to speak about the the vaccination for the influenza A and B. I'm told that the vaccines available in the public sector free is what we call a 3-strain combination, and the ones that are available in the private sector is a 4-strain combination, and therefore a better one. Is that so? And is it possible for us to have the 4-strain combination in the public sector? Thank you.
So I want to thank you for raising the issue of flu vaccinations and the issue of trivalent and quadrivalent. There are issues in a country. Dr. Nandram, should we go down that road?
Your call, Minister.
Okay. There are some issues with the quadrivalent vaccine which we do not use in the public sector that are causing some cause for alarm. In the public sector in Trinidad and Tobago, we have always used the trivalent vaccine. I will let the doctors go into more detail. Trivalent simply means tri-3. It is effective against 2 strains of influenza A, I think H1N1 and H2N3, I believe,
think so.
and 1 strain of influenza B, which are the main viral culprits that circulate. We are not using the quadrivalent. It doesn't mean that the quadrivalent is better than the trivalent, but I will let Dr. Nandram speak to that. But be aware, there are some issues with quadrivalent vaccines being used in other countries. And I want to assure the public that what you receive in the public sector is a safe trivalent vaccine. Having said that, the number of vaccinations that people are coming for is unfortunately declining. In week 4, which was last week, we gave out 6,963. We were aiming by now to be delivering about 10,000 doses of vaccines. Week 5, which is this week, that has decreased to 5,329. To date, we have given out 27,951. This figure should be up to about 40,000 by now, especially with the upcoming fall and winter season in the United States and with repatriation flights, where persons from North America, England, and the colder climates will be coming home, albeit in smaller numbers, but they can also be bringing home the influenza virus that is circulating in the northern hemisphere at this point in time. So it is absolutely vital, and I make the plea again, for key sectors of the population, especially the elderly with pre-existing conditions, diabetes, hypertension, obesity, asthma, cancer, those conditions wherever it causes your immune system to be not as strong as it normally is in a regular healthy person like you prior. Children between the ages of 6 months to 5 years. Our pregnant women, please get vaccinated. The vaccine is perfectly safe for both you and your baby, regardless of the month of your pregnancy. Anybody with non-communicable diseases, please come. Let us get these figures up to about 10,000 a week. I will now hand you over to the doctor who can more expertly talk about quadrivalent and trivalent vaccines.
Thank you, Minister. To put this very, very simply, a trivalent vaccine addresses 3 virus strains, and a quadrivalent vaccine will address 4. The concerns we've had around quadrivalent vaccines revolve around adverse events and some safety and security type reactions, and it's for that reason that we've consulted not only with subject matter experts, internal and external to the ministry, but also some of our technical partners, and have consistently opted to procure the trivalent vaccine. It's noteworthy that during vaccine development, major health agencies do modeling to predict which are the strains that would most likely be in circulation during any 1 year, which is why it's very important to get flu vaccination shots every year, because every year the strains may change. So the majority of the predicted strains to be in global circulation are well covered by the trivalent vaccine offered in the public health facilities. And the additional strain that is not in that trivalent vaccine isn't in a significant degree of circulation in Trinidad and Tobago. So the additional risk posed by adding an additional strain and moving toward the quadrivalent vaccine was outweighed by the risk. And it's for that reason that we, at the Ministry of Health, in the interest of public safety, stuck with the trivalent vaccine.
Sorry. I just want to come back to one thing, because Pryor asked this question a few weeks ago, and he asked the question, Pryor, if you will remember, you said you got the vaccine, the flu vaccine, in December of last year, and you had asked whether you need to get it this year. I think we at the ministry, and I'm glad you raised it, I think we at the ministry need to change the way we talk about this vaccine. And stop saying it's a yearly vaccine, because I think that confuses the public, and say it's a seasonal vaccine. I think we could agree on that. So the flu season, and Pryor, I really want to thank you for raising this issue. The flu season runs from October of any year to May of the following year. So Pryor, you were vaccinated in December 2019. So that flu season, which started October 2019 and finished in May this year, you were vaccinated for that flu, which the experts thought would have been circulating there. This flu season started this month, October 2020, and will end in May 2021. So we have to get away, and I think we have to accept some responsibility at the Ministry of Health to stop saying it's a yearly vaccine, but it's a seasonal vaccine for the seasonal flu, which runs from October of any 1 year to May of the following year, regardless of which month in the year you got it. So I hope that clarifies it, Pryor, and I really want to thank you for raising it again. Thank you very much.
Thank you very much, and I believe Dr. Hines has some additional info to add about the flu vaccines. Dr. Hines?
Thank you, Ms. Alcantara. Just to expand a bit on what the Minister had mentioned with regard to the concerns around that quadrivalent vaccine, we're flagging that really as out of an abundance of caution, but it's really more of the quadrivalent vaccine that was being used in Southeast Asia. Now, there's several different types. So we're not absolutely pegging the quadrivalent vaccine that we have in Trinidad in the private sector to that type, but we are flagging the fact that we are using in the public sector the trivalent, and the quadrivalent in Southeast Asia, one of the several types of quadrivalent vaccines, or I think it was two strains, two of the several types of quadrivalent vaccines had some additional health concerns for which they issued their warnings and they did their own retractions. This may not apply to whichever quadrivalent vaccine may be in use in the private sector, but we just mention it out of the abundance of caution and out of the abundance of information that we want to ensure we provide to the general public. So we're not saying that it's the same vaccine that's in use in Southeast Asia that is in use in the private sector, but we're also pointing out that whether or not it is the trivalent vaccine which we have in the public sector does cover all of our circulating strains of flu, and we are quite happy with its coverage and performance. So we would not say that the quadrivalent is better than the trivalent, which is one of the questions that Mr. Bihari, I think, asked. Back to you, Candice.
Thank you much, Dr. Hines. And we go to CL Communications for a follow-up question.
Hello again. And I just wanted to find out the national director, which Mr. Dael Singh spoke to, was that person sought from Trinidad, or did we have to turn to outside of Trinidad to seek that person? And what sort of qualification does somebody of that nature have? Thank you.
The recruitment of that person is handled administratively by the public service. As Minister of Health, I never get involved in directing the public service who to hire, where to source from. The post will come with a list of qualifications. It will come with a proper job description with qualifications aligned to the responsibilities. I would not have those details on me. That will be handled administratively by the public service, but it is based on a proper job description to make sure that the qualifications match the responsibilities of the job.
Thank you very much. And TV6, we're ready for your follow-up question, please.
Okay, thank you so much. I just have a quick question. I would have seen that Russia would have sent vaccines to Venezuela. Venezuela did a trial of that. And then I believe it was in the last week or so, Venezuela would have announced that they would have come up with an effective COVID-19 vaccine. Is Trinidad and Tobago at all liaising with Venezuela over that? I know we have signed on to COVAX. I'm just asking for clarification.
So, thank you for the question. Trinidad and Tobago, as far as vaccines for COVID-19 is concerned, the policy position that I took to Cabinet, and I have a Cabinet note on this, is that Trinidad and Tobago has signed on to the COVAX facility, and the COVAX facility only at this point in time, which is supported by WHO. So there are about 12 to 15 candidates in that program. I will have more details to share with you next week, Saturday, hopefully, because we made our initial down payment by the deadline date of October 9th, I believe. Having made that down payment, we are now considered a shareholder of COVAX, and COVAX is hosting a shareholders meeting, virtually of course, on Monday. So I will be there. Other personnel of the Ministry of Health will be there. This is the first COVAX shareholders meeting, and let's wait until I have more information on what transpires on Monday, and hopefully I can report that to you next week Saturday. But at the time, that is the only vaccine platform we are dealing with. It includes vaccine candidates from England, the United States, Europe, and China. In addition, Sinopharm is one of the vaccine candidates in COVAX, but in addition, we are also having some separate talks with Sinopharm. And all these vaccines are either in very late stage 2 or are now completing late stage 3 clinical trials. Thank you very much, Alicia.
Thank you very much for that clarification, Minister. And our final question today from Newsday, please.
Hi, good day again. Paula Linder here. So my last question is about bars and restaurants. What, if any, measures are you all planning to put into place soon? Because as you can see, more and more places are having to close down.
Okay.
Yeah, that's it.
So thank you. So the decision on what industries could be opened is based on the public health measures. And if you will look at what globally, this is not, I think sometimes we forget that this is not a Trinidad and Tobago thing, it's a global issue. Any environment where it is difficult to wear masks for prolonged periods of time, socially distance and so on, are causing problems around the world. From day one, nurseries and preschools where it is impossible for children to wear masks and socially distance have been closed. I don't want the narrative to be that we are anti any type of industry. It is not that. We are anti-COVID. we are anti the elderly dying. We have 105 deaths, 106, right? That is what we are anti. So any type of environment where it is difficult to social distance and wear masks are causes for concerns. you would see we applied those measures to the Arima Race Club. The racing can go on, but we can't have hundreds and or thousands of persons in that type of environment. We have to protect the healthcare system. We have to make sure healthcare workers can get a breather, and they are getting a very good breather right now over the past couple of weeks. There's a hospital in a particular city that are now refusing their regular patients because they have converted that hospital to a COVID hospital. So if you're a pregnant woman, if you have a heart attack, you cannot get care in that particular hospital, in that particular city, in that particular country. That is what we have avoided so far. But as our numbers dictate, we will advise the decision makers, which is ultimately the Honorable Prime Minister who makes the ultimate decisions on what level of risk we can take going forward in any industry, in any, whether it's preschools, nurseries, or other places. Thank you.
Thank you very much, Minister Dael Singh. We have come to the end of this morning's media conference, and as we close off Breast Cancer Awareness Month and go into Diwali and Christmas seasons, we remind you that if you have persons in your home that are vulnerable, cancer patients, persons with diabetes, hypertension, and the elderly, please discourage persons, even other family members, please discourage them from visiting. Please get the flu vaccine, this new season's flu vaccine. And remember to wear your mask over your nose and mouth.
As a father and a husband, I believe it is my role to protect my family. As a Trinbagonian, I also have a responsibility to my fellow men. We can't protect our loved ones and our country from COVID-19 if we all wear a mask over our nose and mouth in public, stay at least 6 feet away from others, stay home, especially if we are ill, wash our hands often with soap and water and use a hand sanitizer, cover our